our organization is our website, and it's used as an informational resource. Through our website and toll-free helpline, we connect patients to programs that provide financial assistance for healthcare expenses, including but not limited to medications. We do have a special guest today who I will introduce shortly, but first I would like to go over a few housekeeping rules. If you have questions, feel free to ask them at any time by typing them into the questions bar of your control panel. Either me or a guest will answer them at the end. The webinar will be recorded and can be found on the webinar library page under the Getting Started tab. You may also find similar webinars under that same page. Lastly, our guest will provide her contact information at the end should you have any questions following the webinar. And with that, I'd like to begin. Today's topic is Empower Your Patients to Self-Manage Their Diabetes. Diabetes is a disease that individuals must manage themselves, but frequently they do not have the tools or the confidence to do so. Join us and learn how you may empower your patients living with diabetes to successfully self-manage their disease. This webinar is co-sponsored by the Texas Association of Charitable Clinics. Kathleen Gold, registered nurse, will be the guest speaker for this webinar. She is a certified diabetes educator employed by the Diabetes Research and Wellness Foundation. In her role as Outreach and Education Director, she is a member of the Medical Advisory Board. She is also the operator of a national diabetes helpline and is the editor of Diabetes Wellness News, a national monthly publication that provides support to patients and families of those suffering from diabetes. She is also the webmaster of diabeteslocal.org, a website of local resources nationally. Kathy graduated from Dewville College in Buffalo, New York with a bachelor's in nursing and received a master's in nursing from the University of Maryland. Her nursing experience is varied and she has held a variety of positions. At NIH Clinical Center in Open Heart Surgery, a head nurse of a medical ICU, and a home care nurse, where she became interested in working with those living with diabetes. Okay, thank you for joining us today, Kathy. I'm going to switch the screen and pass the mic to you.
Thank you very much. I appreciate that introduction. I just want to talk a little bit about diabetes today and kind of give you a little bit of information about how you might empower your patients. I'm speaking to the choir here when I tell people that diabetes is a huge epidemic in the United States and worldwide. There's over 29 million people that have diabetes, and 1 out of 4 of those folks do not even recognize it. And then, to me, the scarier number are the 86 million people that have prediabetes, and that's 1 out of 3 adults have prediabetes. So those are pretty high numbers. So we really need to know how to encourage these individuals to manage their disease, or in the case of prediabetes, change their lifestyle in order to prevent their diabetes. So just a little bit of an overview, so we're all starting from the same page. I just want to, my little graphic here shows you a little bit about what diabetes is. So when you take that first bite of food, your pancreas is going to release this hormone called insulin. And insulin's job is to open the door and allow sugar or glucose to pass from the bloodstream and move it inside the cell or inside the muscle in our body parts in order to provide energy. If you have diabetes, type 2 diabetes, for example, you have what we call insulin resistance. You produce insulin, however, that insulin doesn't work very well. And as you can see in the picture, the door doesn't open. And as a result, we have high concentrations of glucose remaining in our blood. That's about 95% of the people that have diabetes have type 2. Type 1 diabetes is an autoimmune disease. It affects about 5% of the population that have diabetes. And for some reason that we don't yet understand, the cells in the pancreas are destroyed that produce insulin, and individuals with type 1 need to take insulin injections or they will die. So that the end point is still the same. There's high concentrations of glucose in the blood, but type 1 generally we see developing in children and young people, although it can develop at any time in your life. So why do we care? What difference does this make? Well, high blood sugars actually cause a lot of damage to our blood vessels. So if you think of your blood vessels as the plumbing system, you know, those arteries are the pipes that kind of take the blood all around the body. Well, high blood sugars over time cause an irritation to the walls of those pipes. And you're going to get an inflammation process that occurs, and as a result, you're going to get a buildup of fat molecules, cholesterol, different things, and you're going to see it is that in that lower picture that those blood vessels are going to get smaller and smaller and smaller, increasing the risk for stroke, heart attack, or damage to blood vessels. So diabetes has many, many complications. Retinopathy, it's the leading cause of blindness in this country, kidney disease, leading cause of people on dialysis, neuropathy, which is damage to the nerve endings, and that's a very serious complication. People lose the sensation. That's why we see sometimes amputations, because they lose the sensation of pain in the long nerves of the hands and the feet. As I said earlier, stroke, heart disease are all complications, and peripheral vascular disease. So every 24 hours, we have over 4,500 people are diagnosed with diabetes, and 136 people begin treatment for kidney disease. We see 200 non-traumatic amputations, and then 641 people die from diabetes or the complications. So it really is a time bomb, and we really need to figure out how we can really make the changes that encourage people to make the changes that they need to successfully manage their disease. So I think sometimes it's good to walk in someone else's shoes, and I think we have to understand that people with chronic disease, such as diabetes, have to make many health decisions on a daily basis. And sometimes they make good decisions, and sometimes they don't. And a lot of times they don't really understand the impact of the decisions that they're making. So they don't have a good support system in order to enable them to make better choices. What I find in my practice is that patients don't intentionally make bad decisions. It's just that they lack the knowledge or the understanding of what the process is and how things go. So it's really important to engage our patients and educate them. I find that they really need to understand what's going on. I have a clinic at a homeless shelter in the District of Columbia, and I have to say that my homeless patients are my best patients because they get it. They understand. They've been through struggles. They've been alcohol abuse. Drug addiction. They've learned how to make behavior changes, and so that they can be very, very successful. But they also, once we give them the knowledge and the understanding, they're going to be able to make a more educated decision versus just reacting. So they have to understand that their illness is serious. And I don't mean to scare people when I first introduce, the topic of diabetes. You don't want them to become so overwhelmed that they can't even hear what you're saying. But diabetes is a serious disease, but it's certainly one that can be managed without a lot of complications. I mean, I have patients that have had diabetes for 60 and 70 years that have no complications. The research now is showing that although the number of people with diabetes is increasing, we're not seeing as many complications as we were before. And I think that's because we're being much more aggressive with these individuals, and we're really educate them about their disease. And it's another thing that you need to realize is these people are living with this disease 24/7, 7 days a week, 365 days a year. They have no vacation. That's hard work, and I think you have to give the patient credit for the efforts that they put in, because it is not easy. But you also need to let them know that there are options, there are choices, and that they do have the power to change their own behavior. So we need to change, I think, our thinking when we work with these patients from the concept that they're non-compliant, that they aren't doing what we tell them, that they're not paying attention, and we need to change that thinking to that patients are successful in managing their own disease. They've not learned the tools. They have not yet engaged in their own care. So I think once we move them from being uneducated and lack of knowledge to being knowledgeable and independent in their self-management, you're going to see a big change in the success of their control. So I think this picture kind of shows you, we kind of assume things. You look at things at face value, but sometimes things are not as they appear. And we need to kind of take a step back and look at what we're doing, and are we doing it the best way, or are we doing it the same way we always do, and we're not really seeing much change in what we do. I don't see, I don't never tell my patients that their numbers are bad or their numbers are good, that they're a success or a failure. We want them to change their behavior. We want them to make choices. We want them to make good choices. But we have to be able to uh, kind of move them in that direction. Saying you want to be healthy is a rather abstract um, concept for many people. So that may not, just saying, well, we want you to be healthy, may not be enough of a motivator. We have to kind of find what can push their button, what's going to really motivate them to make their changes. And sometimes patients aren't ready for change. I do a national helpline. I talk to people across the country. And frequently people call and they're just getting information. They're not really ready to take that step. And I think we have to be respectful of that. But we continue to give information because at some point, the fact that they're coming back tells you that you're kind of cracking the facade. You're going to move them forward, but you need to be very patient because you want them to be successful. I really get upset when I have patients come in and say, well, the doctor said if I don't do this, he's going to put me on insulin. Or I did this to the doctor said I did this to myself because I am a couch potato and I don't get up and exercise. Guilt doesn't really move people forward. It doesn't really, if anything, I think it kind of closes the door. So we want to be able to give patients options. Let them get engaged in the conversation. We want them to understand what they can do to actually make changes in their care. And I think we all have to recognize that perfect control isn't possible. Even when people with diabetes are doing everything perfectly, it's not always going to work because we're human and we live with diabetes second. So I think you have to realize that they have a life, and sometimes life can get in the way. But we don't want the diabetes to take over their life. We want them to have their life and control their diabetes within that life. So how do we not? I think I just think about what you do in your own practice or with your own interactions with patients. Do you give them advice? Do you kind of misjudge the sense of importance regarding their behavior change? Do you try to scare them, argue with them, blame them? Just kind of criticize what their attempts are? Are you kind of jumping ahead and thinking that they should be ready, even though they might have had diabetes for 10 years, they may not be ready to make those changes yet. So, I mean, that might be frustrating to you, and I know on my helpline I get calls from spouses all the time saying, oh, my husband won't do this or he won't do that. But they have to be ready, and you have to kind of keep providing information, keep being very supportive, but recognize that they're not going to change until they really see that there's a need. And we also, you don't want to take away their control, because if, I don't know how you all feel, but if someone tells me I can't do something, that's just going to make me even stand firmer and not move forward. So you want to certainly engage them in the process. So how do we engage patients? And I think this is something we've all kind of some of the skills we've lost is we don't listen. I don't know how, we don't listen, period. We have to jump into the conversation. But if you can just be quiet for a little while and let the patient talk, you're going to get lots of cues about what they're feeling, what kind of obstacles they feel, what kind of barriers they might have, what kind of concerns they might express. But if we keep jumping in and interrupting them, we're not going to get that kind of information from the patient. So listen. Listening is very, very important because remember, this is the patient's disease. They have to manage it. If the more we listen, the more information we're going to gain and learn about this individual, and we're going to be able to guide them in the right direction. We have to understand that what's involved in behavior change and motivation. What's going to motivate them? Do they have young children that they want to see grow up? Do they want to see grandkids? I mean, you have to kind of find that button that's going to make a difference. It's going to kind of attract their attention, to make them pay a little bit more attention. Do we give patients lists of things to do? You need to do this, you need to do this, you need to do this. Or do we engage the patient to actually sit down and think about, all right, these are all the possibilities. You tell me, you want to go in and, we want you to exercise, and we want you to eat a healthy diet, and we want you to take your medicines on time, and that's just, that's what we want them to do. But they have their own lives. They might be raising their children, they might be feeding, they might be taking care of elderly parents, they might be working a full-time job or multiple full-time jobs. So we're just adding to that burden. So we really need to be able to sit down and figure out what's the priority here. And by listening to your patient, you're going to be able to see this might be, what's the low-hanging fruit? What's the one thing that they might be willing to engage in making a change? It might be that they'll just eliminate regular soda in their diet. And what I find is if I can get them to make one simple change, then what I can do now is, oh, look at how successful you were with this. Let's move on to something else. So small baby steps, because once people start being successful, that's just going to motivate them even more, because now they have the confidence. They feel that they are capable of making these kind of changes. And I try not to let my patients get overzealous and making, choosing 16 different things to do. Let's just focus on one little thing. And if we can do that well, then we'll move on to the next thing. And then kind of coming up with a shared care plan. If you don't engage the patient in that plan of care or those goals that they want to select, if you select them, more than likely the patient isn't going to be engaged in the process at all. So what options do we give people, and do we give them options? Okay. Do we respect their opinion? Are they open to the information? I know there's so much information now on the internet. There's so much information out there. A lot of it's misinformation, but it's important that you get the patient to express what information they have. I always ask my patient, what do you know about diabetes? Tell me what you think it is. What do you think? What do you think is going to make a difference? Why are you concerned about diabetes? And many of them will share, my father died of the complications, and I don't want that to happen to me, or I don't think I can do anything about it. My whole family has diabetes, so therefore I'm going to get it. I don't have a choice here. There's no way I can make a difference. But you want to be able to open up that information and kind of, you don't have to respond to it always, but kind of remember it's going to give you a little bit of better understanding of where this patient is coming from, so that when you do start making recommendations or having discussions with them, that you kind of know what framework they're coming from. And you want to focus on them during their appointments. You don't want, try not to have a lot of interruptions. You just want them to be the person in charge. Now, I do a lot of group work. We do group visits. I've done them with nurse practitioners, and I'm doing them with a family practice medical group. And I really find that that's a very effective way of dealing with diabetes, because I don't have to say so much. I can depend on the group to pipe in and say, your blood sugar was 600. Why would you allow that? What are you doing? Why do you think that's good? Don't you know what's going to happen to you? I don't have to say anything. So you want them to be engaged. So a group is one way. Now, with my homeless patients, I found that it was much more effective for me to meet with them on a one-on-one, because I think they do so much in meetings and things like that they never get that individual attention. So you kind of have to look at your patient and decide, would they do better in a group with a lot of input, or if I just work with them on a one-on-one, is that going to be more effective? You may not have the option to be able to make those decisions, but certainly that might be something you want to consider. And don't be insulting to them. There is some research out there for alternative medicines and things like that. there are some family remedies, vinegar, and taking different apple cider vinegar is the latest one I think I've heard that they take vinegar every day. Well, there's these are cultural things. If it's not going to hurt them, you don't want to. You don't necessarily have to stop them. You want to make sure that they understand, that there's not a lot of science for this, but if this helps them feel better, or what I have them do a lot of times when patients are talking about taking supplements and stuff is I say, all right, if you want to try this supplement, let's do it this way. As long as it doesn't have any contraindications with their other medicines, why don't we try the supplement. We'll give it a trial for 3 months. You know what your blood sugars are now. We're going to try this new supplement, and you're going to try it for 3 months, and you're going to test your blood sugar, and you're going to see if it makes a difference. If it does make a difference, well, that's to your benefit. But if it makes no difference, I can save you a lot of money because you won't have to be spending money on this supplement. So rather than just saying, oh, none of that works, I think you have to be a little bit more open, because then they're going to respect you because you included them in the decision-making process. And that's so important if you want to empower your patients, making sure that they're included in any decision-making. You need to stay current with information out there. There's a wonderful website. NIH has a wonderful website on supplements and keeps you current about what's going on, so that's really worthwhile. And we find that patients will continue their self-management task for a longer period of time if they decide what they are. So people with diabetes can live a long and healthy life, and I think we need to tell them that that's really important, that they know that's the case, that diabetes is not their fault, and it doesn't have to ruin your life. You can live a very healthy and successful life. So I want to go over a little bit of, these are the self-care behaviors that are established by the American Association of Diabetes Educators. And these behaviors are things that when I educate patients, that these are the behaviors we're kind of focusing on. So we're going to go over those a little bit, and we'll give you some examples. So first of all, of course, healthy eating. How do you make patients make better food choices, reduce their portion size, and follow a meal plan? Those are the kind of messages we want to get across to them. So a lot of times I spend some time with them going over, what do you eat? Let's make some discussion here about what you're eating. How do you think that's going to, if they're drinking a lot of juice, well, how do you think that's going to affect your blood sugar? Are there other things that maybe you'd be willing to drink? Would you maybe put a little lemon in water or something like that? So giving them options to be able to make decisions about food choices. If they always eat in a fast food restaurant, what options do they have? If you're not familiar with, there's some apps out there that have, Calorie King is the one I'm thinking of. Calorie King is a free app on a smartphone, and everyone has smartphones these days. I mean, even my homeless patients have smartphones. But it gives you a listing of all the fast food restaurants and all the food there, and you can go in and show them that maybe a grilled chicken sandwich would be a better choice than that hamburger and fries. So how to educate them. I use the plate is one of my teaching tools. MyPlate.gov is a wonderful resource about it has lots of information about portion control, and the goal is that half your plate would be vegetables, a quarter carbohydrate, a quarter protein. But I gotta tell you that if I went in with my patients in the beginning and said you have to, that are not eating any vegetables, and said you now got to go to a quarter of your plate is going to be pasta and a half vegetables, they won't come back and see me. So what you've got to understand is you have to make these choices or these changes very gradually. So let's negotiate here. What if we did, would you be willing to maybe eat, instead of a whole plate of pasta, 3/4 of a plate of pasta and add just a quarter of a vegetable, either a salad or, some broccoli and cauliflower. But would you be willing to make those kind of choices? Or would you be willing to maybe, if you're not willing to do a quarter, would you do an eighth? So you make baby steps, but baby steps over time become giant steps. So you add those baby steps up, and you really. So let's see. So nutrition facts is another thing, educating people about how to read a nutrition label. Serving size, I think, is probably the most important thing. People need to know. These nutrition fact labels are very difficult to read, and I find that we actually did a study with patients to see how they would score, and it was pretty bad. So hopefully that they're going to make some changes here, and we're going to see some improvement. So, but anyway, serving size is the most important thing, and recognizing that the serving size may not match with the servings per container. So in this case, if you ate the whole container, you would have to multiply all these numbers by 2. So instead of 31 grams of carbohydrate, we would actually be 62 grams of carbohydrate. So showing the patient, oh, if you know this is what you're eating, do you realize that this is how much carbohydrate you have? And I kind of use the rule of thumb of anywhere between 45 and 60 grams at a meal. I mean, if I had a dietitian that worked with me, then we were able to make better decisions based individualized. But sometimes when I just have to give them some overall guidance, I give them that recommendation. But showing them how to make the nutrition label and recognizing that they don't have to look at every single nutrition label when they go into the grocery store the very first time. Just let's find some healthy cereals that you could like. And looking at that Calorie King app or something else that might be very, very helpful. To help them understand that they could make, a healthier decision. Being active is really, really important. We want patients to be exercising. We want them to be active because that's going to make a big, big difference. We want that's the most effective thing that we're going to find that's going to make a change in weight loss and blood sugar control is physical activity. And I have to say it's the one thing that I have the hardest time to convince people to do. Once they get started, they're very motivated. They realize that they feel better, they have more energy, but to try to get them to take that first step. So we talk about giving them options. Would you be willing to walk to the mailbox? Would you be willing to walk to the corner? That's not, I don't want you to run. You don't have to jog. I want you to do something that's fun. But can we start moving more? I have a group of seniors that I used to work with, and we used to say that they would have to march in place during TV commercials. That was the one thing we would give them. Would you be willing to march in place during the commercials when you're watching TV in the evening? Well, you can get a lot of exercise in if you did that, and if you're marching in place, you're not going into the refrigerator. So that's a good thing. And the good news about physical activity is people generally start to lose weight. Women generally have to reduce calories and exercise in order to lose weight. Men generally are fairly successful if they do one or the other. Life is not always fair, as I tell them. Lower your risk of heart disease, and we know that diabetes does increase the risk of heart disease, and it can reduce the need for medications. It increases actually people's energy level. The biggest excuse, I live outside of Washington, D.C., and, every long commute, so we just got named the worst commuting place in the country. So you can spend 2 hours in your car. So people are saying, well, I don't have time to exercise because I'm sitting in my car all day. But actually, when I can get them out to walk, maybe on their lunch hour during their break, or walking to their co-worker's desk instead of emailing them, those kind of things. If I can get them to just think about moving a little bit more, it's going to make a difference. But the other thing it does is it releases these hormones that make us feel good about ourselves. So it's going to overall improve the person's health. We want to keep it fun. It doesn't have to be running. They don't have to jog. I have one lady that got into belly dancing. I have other people that like Zumba. Water aerobics, or even water walking is a wonderful exercise for people that are severely overweight or have arthritis, and allows them to move without kind of pain on those joints, and it's very effective. I actually take a water aerobics class, and one gentleman in our class has lost over 40 pounds. So it can be very, very effective. I encourage people to do it with someone. Get the family involved. The more support a person with diabetes has, the more successful they're going to be. The husband and wife plan on going for a walk every evening after dinner. Great way to some time alone, but also to get that exercise in. And you don't want to nag about it. You want to just kind of offer those opportunities, encourage people to do those kind of things. Blood sugar testing, I think, or monitoring is very, very important. It gives patients information that they don't necessarily have. I think I like this quote. It's like a compass to a mountain climber. You can't tell where you're at. It allows you to tell you. It shows you where you're at, so you can reach your goal. So guidance, most people say, well, we don't, patients never do this. They don't write down their numbers or everything. What I found with my homeless patients is that my best success has been I was able to get the software. All the meter companies have software that you can download the meters into the computer and have a printout. My patients never used to keep a logbook. Since I started using the computer program and downloading all the meters, I can't say that my patients ever forget to bring their meter, because I show them. We print it out. We look at it. We look at the numbers. What do you think happened? It does it by time of day. It can do it by day of the week. It can look at what it is over time. We change your medicine. We can look at this. So I'm using that information. So the patients are much more willing to test, because we know that we're going to sit there and we're going to discuss what this means. And they're going to be a little bit more cognizant of, oh, well, you know what, on this day, I really had a lot of stress. I had a lady come in this week that just did that. She said, I had a lot of stress at home, and look at what happened to my blood sugar. She goes, I didn't realize stress could do that. So if the patient learns about what those numbers mean, they're not good or bad numbers, they're informational numbers that they then can, if you've empowered them, can act upon. They could maybe adjust their dose of insulin. They might reduce the amount of carbohydrate they had. They might go out and go for a walk. They might recognize that the next meal they're going to have to eat less carbohydrate, or the combination of what they ate that time was too much, and that next time they're going to have to make better choices. So it's very, very important that if they do that, that you recognize the effort that they're putting in, because it's painful and it's a nuisance. So, make sure that if you do ask people to test it, you do engage them in that process. 2 hours after a meal is a very important decision, because that's going to give them immediate feedback as to what that meal, what the effect of that meal was on their blood sugar. Generally, I work with as long as it's between 140 and 180. That's kind of the goal that we're looking at. But it allows patients to kind of get an understanding of what the numbers mean and actually do something with those numbers. Taking medications, people with diabetes are on multiple medications, very confusing schedules, and it's very hard to understand why they're taking them. They don't understand. That's the first thing I always spend time with my patients is, what medicines you're taking. Do they know what medicines they're taking? I always print out from our EMR the list of their medicines that they can keep with them at all times, because the names are very confusing. It makes it very, very difficult. But, as I say, in an emergency situation, you want to know what that white, pink, and blue pill all are. So you want to have this with you if you had to go to the emergency room. But if you educate the patient, engage them in the process about what medicines you're going to take, you're going to find that they're going to be much more willing to take those medicines. If all right, we're going to have to start you, we might need to start you on insulin. These are the kind of insulins that are available. What would you be willing to do? We could give it to you once a day. We could start with giving you a short-acting insulin before your largest meal. What are you willing to do? What kind of options? How would this affect your life? Let's see how we could work this in. But engaging them in that process is going to make a big difference. And there are so many medications now. When I started diabetes education, I had 4 or 5. We're now up to 80 different medicines. We can work on the GI tract. They can work on the pancreas. They work on the liver. They deal with insulin resistance. There's even one now that works on the kidneys, so that patients before, without this medicine, blood gets filtered through the kidneys, it pulls the sugar out, and then at the very end of the distal tubule, it reabsorbs that sugar. Well, this new medicine blocks that reabsorption, so people are peeing out all their sugar and lowering blood sugar. So there's lots of different choices. Have a discussion with the patient. What are they willing to do? There's some side effects. Be upfront. These have this side effects. This is what you have to take it this many times a day. But engaging them in the process of the decision making is going to make it much better, and you're going to have much better success in making sure that they're going to follow through. And I think we make regimens so complicated. I mean, if you just read the instructions here, I wouldn't remember to do all this. You'd have to have a calendar and alarms and to tell you to do all these things. But I think we make it very, very difficult for patients. I know when I do an assessment with them with their medicines, I find we tell them to take sulfonylureas, which we should be taking before breakfast and before dinner twice a day. But we don't say before breakfast or dinner. We say twice a day, and you will find the whole spectrum of what a person interprets as twice a day, which could put them at risk of a low blood sugar if you don't give them the right information. I always encourage my patients to make the pharmacist your best friend, because the pharmacist can look at all the medicines and kind of help them make decisions. Maybe we could do this less expensively, or there's a generic that might reduce the bill. So certainly doing those kind of things are going to make a difference. And then, like I said, I think it's very, very important that we include patients in that medication decision and explain how they work and what they actually do. Patients need to problem solve, and we want to kind of help them put the pieces of the puzzle together so that things can work out well. Hypoglycemia is an excellent example. How do we prevent people from dropping their blood sugar too low? Do they understand that if they take this medicine and skipping a meal could make a difference, or if they took the wrong dose of insulin, or if they did much more exercise than usual and didn't eat anything? So making sure that they understand what the symptoms are and what you need to do, how you treat that as far as sugar goes, giving fast-acting sugar, chocolate's not a good suggestion, juice, glucose tablets, so that they don't overdo the treatment, because that can cause lots of problems as well. Hyperglycemia. We don't always give patients ideas of what to do if their blood sugar goes too high, because they forgot their medicine, or they ate too much, or they get ill, or they have stress. Going out for a walk, drinking more water, and letting them know at what point should I call my doctor to discuss what I need to do if my blood sugars are too high. And the symptoms that they have, they don't feel well when they see these big fluctuations. So we want to make sure that they know what to look for and recognize that this can be a serious problem. And how can they kind of figure out what to do and work with the team in order to improve control. We want to reduce the risks of stopping smoking, making sure that they're getting healthy checkups, eyes, their teeth, blood, cholesterol, A1C, blood pressure, getting their foot exams, and then all those daily things. So as you can see, this is a lot of work. This takes a lot of effort. We're all busy with our lives, but can you imagine having diabetes on top and having to do all these other things as well? And how many days of work do you miss because of all this? I think sexuality is another big issue to talk to patients about. This is not something that necessarily they feel comfortable bringing up, but diabetes certainly can affect sexuality. And there's many treatments, both for men and women, available. So making sure that you incorporate that. That's having that discussion with the patients is really going to give them, I think, a sense that they have some control, that this disease isn't taking over their lives. Being healthy cope with the diagnosis. It's not easy. And adapt to lifestyle changes. You've been living one way all your life, and now all of a sudden you can't eat, and you see all these things taken away from you. And I think making sure that patients have a good support system. And and I encourage patients to bring their family members in to visit, because if the family understands and they're supportive, and everybody, what I say to my with group visits, we talk about your wife shouldn't just be cooking this meal for you. She should be cooking the whole family, because if you have diabetes, your children are at risk. So we want to make sure that everybody is being cared for. Diabetes is a lifelong process. We need to set realistic goals and be realistic in what we expect people to do, and let them set those goals. We don't want to do that for them. We want them to be able to set their own goals. We want to encourage them to make sure that they have a support system, whether it be family, friends, a church group, work, and encourage them to make sure that someone always knows that they have diabetes in case there is a problem. And then I think give them a pat on the back. I always like to be able to say, oh, you're my poster child. You know, this is wonderful. I mean, that just gives them so much more confidence to go on and jump the next hurdle. And then being educated so that they know, all right, things are not going right here, and I need to get help from someplace else. So one of the things you could do is do goal setting. I came across this when I was researching this project, and I thought, well, a Jumpstart pledge, that's a great idea. You know, rather than a goal, a pledge. You know, I want to, it's just like setting a goal. You just change in the name, but maybe that might be something that they're more willing to do. And then you adjust those pledges or those goals as time progresses. You know, and sometimes you have to discuss, all right, listen to the patient. How are you doing with your goals? Well, I wasn't able to. Well, then let's discuss the barriers. All right, what barriers existed, and how do we overcome those barriers? What can we do to make it easier for you? Or maybe we need to readjust because maybe this kind of medicine isn't going to work for you. Maybe we need to look at something else. Okay, so let me just turn this back over to Max.
Okay, Kathy, thank you for that presentation. You did a really great job, and you offered a lot of great insider info, especially related to how patient understanding can lead to patient engagement so they can eventually be their own advocate. We really like to have someone like Kathy to be able to provide us an in-depth look into a popular topic such as diabetes. You can put the great information she provides to work by making an informed decision, all the while utilizing NeedyMeds resources to help with financial costs. So with that, I would just like to briefly show you how to use one of the NeedyMeds database resources for diabetes, and then we will open up for questions. Okay, so here you see the NeedyMeds homepage. We're going to go to the Patient Savings tab, and you're going to see a lot of options here. We're going to move to the Diagnosis Specific column under Diagnosis-Based Assistance, and we're going to click that. After clicking on Diagnosis-Based Assistance, you're going to see a few options down here. We're going to search by diagnosis. You're going to see an A to Z index, and then under that A to Z index, we're going to go to D for diabetes. So we're going to move our way down to diabetes, select diabetes, and you're going to be provided with a results list for all the programs related to the diagnosis of diabetes. You're going to see the program name, the summary, the services provided by that program, and the areas of service. So let's take, for instance, the Children with Diabetes Foundation, Supplies for Children with Diabetes Foundation. It provides medical supplies for emergency situations to children who have diabetes. It shows the nature of the program and its range of service. So if you click on that program, you'll just be provided with a little bit more information on that program, such as contact information, a website if they have it, a telephone, and email. So just so when you're calling that program, you'll be able to have the information you need for it. So I'm going to switch the screen now back to Kathy so she can display her contact information again, and we're going to open up for questions. So the first question is, would you please explain a bit more in detail this postprandial testing?
The postprandial testing? Sure. So what we encourage people to do, if they test their blood sugar 2 hours after a meal, you don't want to test any closer than that. So rather than just have patients test a fasting blood sugar in the morning, it's much more effective to get a pattern of what their blood sugar control is over time. So you might find that their fastings are always good, but you might not recognize that after a meal their blood sugar goes up to 200 or 300. So I encourage patients, what I ask them to do is they change up when they test. So one day they'll test fasting blood sugar first thing in the morning, and then they'll eat their breakfast, and then 2 hours after their breakfast they're going to test their blood sugar. And that blood sugar we hope would not go up much more than 50 points. So that's where that goal of 140 to 180 comes in. The next day I might ask them to do it before lunch, and then 2 hours after lunch, and then dinner, and then 2 hours after dinner. And what you'll do is, over a period of time then, the patient's going to start to see a pattern emerge. And you're going to see what blood sugars are over the course of the whole day. And you might find that, oh, it's always low in the afternoon, but it's highest at nighttime before I go to bed. So I might need to make some adjustments in the amount of food that I eat.
Okay, so the next question is, who would I contact to get a copy of this PowerPoint to submit for CE use?
You, I guess, right, Max?
Yes, so either me or Kathy could provide you with a copy of the PowerPoint. If I am to provide you a copy, it will be a PDF of the entire presentation.
If someone's interested in the slide, it's a very large file, but I would be happy to share the slides.
Okay, great. So you could, so to answer your question, you could contact
they could email
either of us.
Yeah.
And so it doesn't look like there's any other questions. So if you would like I said, if you would like a PDF copy of this webinar, you can contact me at webinar@needymeds.org. You can also contact Kathy at the email she's provided on the screen. If you need any NeedyMeds print materials, you can contact our marketing representative, Deb, at needymeds.org. She can provide you with brochures, anything of that nature. So if there's no further questions, I would like to thank Kathy for presenting for us today, and the Texas Association of Charitable Clinics for co-sponsoring this webinar. And also thanks to everyone who's joined us, and have a great day.